Hello everybody, welcome to Part 3 Boards Review. This is a recording of the Day 1 lecture. So today we're going to be going over various topics. We'll be starting with imaging modalities. First modality we'll be talking about is radiography. Radiography uses X-rays to capture images of the patient. It's the original diagnostic imaging modality and is the most widely used. It has a wide array of uses, such as imaging for trauma, joint arthropathy, osseous infection, tumors, other types of metabolic disorders, congenital or acquired diseases and lesions, as well as surgical planning and evaluation. Here's an example of a radiograph of the cervical spine. You can notice a variety of things. So we have the osseous anatomy, which is very clearly visualized here, but you can also see some soft tissue anatomy in this region here. You may also notice these darker, or should I say lighter, densities that are metallic. So these are surgical clips left over from a cervical rib removal. So there was a cervical rib here that has been removed. Modality we'll be talking about is computed tomography. Computed tomography is a fancy version of an X-ray because it uses X-rays to capture images of the patient just like a standard radiograph, but this time it is capable of taking volumetric type imaging, so you can have more information and more detailed information, so you can view the patient from different planes or angles, and you also have the ability to select slices of the patient as opposed to seeing the entire cross-section of the path that the X-rays took. There are some advantages as well because it allows you to see details to address things like acute brain bleeds, or if you have a complicated fracture that requires more detailed characterization for surgical planning, and you also have better soft tissue delineation because of the fact that the X-rays are able to be tuned to be able to see that better. Here's an example of a CT. So as you can see on the left, this is a cross-section, whereas if you had a normal lateral lumbar radiograph, you wouldn't see just the vertebral bodies as well as the spinous processes. You would see everything in front of and behind it. So here, with this plane, in the sagittal plane, you can see more detail of just exactly one slice. So if we notice here, this vertebral body is fractured, and you can get a better idea of fracture fragments and their location. Here is a 3D reconstruction taken from CT data, and again, it allows you to characterize what's going on with this fracture site. Magnetic resonance imaging is also a volumetric type of imaging where it allows you to capture 3D and/or volumetric type acquisitions, and you can reformat them in different planes. Now, instead of using X-rays to capture images, it uses magnetic fields as well as radio waves and then the electrical currents that those magnetizations cause. So the advantage of MRI versus a CT is the fact that it has better soft tissue delineation versus the CT, but the one negative is the time it takes. So areas of the body that have a lot of inherent motion, such as the heart or the lungs, can be more difficult to image because there's always motion there and the acquisition time is long enough to where you'll have a lot of artifacting. So another reason to use MRI is to decide what is going on if, say, a CT doesn't show it as well. So if you're characterizing a fracture and you can see the bony fragments, but you're not certain if there's any kind of surrounding soft tissue stuff, the CT may show a little, but the MRI will show in much greater detail, and it'll show you things that the CT will not. So here we have an example of some basic sequences on MRI. On the left, we have T1 weighted imaging, and the reason you can tell that is because of the density, or the intensity, I should say, of various tissues. On the right, we have a T2 weighted sequence. So the weighting has to do with the characteristic relaxation times, it's called, of various tissues. So water tends to have a long relaxation time, so when you have a T2 weighted image, it tends to be bright. So the CSF here in the spinal canal is very light on a T2 weighted image, but on a T1 weighted image, it's not as bright. It's more medium intensity. On CT, cortical bone is always dark because it quickly loses its signal, and fat is usually bright because it can maintain its signal for a longer time. So this slide is depicting various signal intensities that you'll see on a T1 weighted sequence, with black again corresponding with cortical bone along with rapidly flowing blood, and the reason for that is since the blood's flowing so quickly you lose its signal. Low signal intensities such as ligaments, muscles, and tendons tend to be kind of a fluidish intensity or water. Now with that you can see examples of muscle here. And then fattier tissues tend to be like intermediate high. So here you can see the adipose tissue on the outside, as well as the fatty bone marrow inside of the femur here. So on this slide, we're seeing the signal intensities for T2 weighted images. So you can see here that the low signal intensity again is corresponding with cortical bone as well as rapidly flowing blood. So here in the dural venous sinuses there's blood flow. And low signal intensity would be, again, ligaments, tendons, and other types of organs, but here in the brain we can see a difference between the T1 and the T2 weighted sequences with the white and gray matter. You can see kind of how they almost swap signal intensities. But what this also allows you to do is to see or characterize a lesion within the brain. So something we can do is we know fluid is bright on T2, as you can see here in the ventricles, and dark here in the ventricles on the T1 weighted image. But here we have this surrounding signal intensity around this circular mass, and we can see it kind of follows what the fluid is doing, so we know there's probably edema or fluid in this region. So on this slide, we're using the MRI to determine the presence of injury, in this case an acute lumbar hyperflexion injury. So we're suspicious of acute compression fracture at L3. As you can see here, there's some deformity to the bone as well as on the T2 weighted image, but what we can also do is we can analyze the signal intensity. So on the T1 image, there's some extra darkness within the vertebral body of L3 that's not present at surrounding bones. And then on the T2 weighted image, we have some light signal intensity that again is not present in surrounding bones, suggesting edema or swelling, so to speak, within the bone, indicating fracture. Again here, this is just showing the difference in T1 and T2, looking at the liquids or the fluids, and then judging that this is the edema around it based off of the fact that it's following the fluid signal intensity between the two types of imaging, or just sequences, I should say. Ultrasound is a modality that can be excellent for soft tissue evaluation, but it's limited to more superficial use because it functions by using essentially reflected sound waves, and the deeper within the body a specific part of anatomy that you're interested in looking at is, it'll be more difficult to get a clear picture. So if you have like a superficial tendon, like within a knee or a shoulder or a wrist, ultrasound can be great at evaluating that, and it also has the advantage of allowing you to evaluate motion or have these movies essentially to see how things are functioning. Here are two examples of ultrasounds. In this case, on the left, we have a supraspinatus tear. So if you notice this dark void within, this is the supraspinatus tendon here. So this dark void is indicative of a tear within the supraspinatus tendon over the humeral head. So this would be the greater tuberosity here with part of the articular surface over here. On the right, we're looking at a wrist, and we're looking for a ganglia popping out between the scaphoid and the lunate. So you can see the cortex of the lunate there, cortex of the scaphoid here, and then there's a dark, or as they say, a hypoechoic mass popping out from that. DEXA, or dual energy X-ray absorptiometry, is used to determine the density of the bone. So if you're concerned about a patient having osteoporosis or osteopenia, you can use DEXA to get an idea of what level of bone mineralization or bone density they have. So DEXA is done by interrogating a specific location. They usually do it in the femoral neck and within the lumbar spine, and then they compare that density to a group of average densities taken on healthy individuals at a given age range. So they usually compare it to a group of 30-year-olds as well as an age-adjusted group, just to see if the person is within range. Here's an example of what a DEXA scan will give you. So you can see on this right side we have the imaged parts with the area they decided to target, and then the marker here kind of showing you where they lie within the graph or the curve. So you would have the young adult score versus the age match score, and then this will show approximately where they're at. So you can see the femur is a little bit worse in this individual than their spine. Bone scan uses a radio tracer, they call it, or a radiopharmaceutical. They inject it, and then it'll move through the bloodstream and release gamma rays. And there's a special gamma ray detector that can localize where those gamma rays are coming from to give you essentially a two-dimensional mapping of where those radioactive particles go. And the reason why this is helpful is it allows you to determine where there's high blood or metabolic activity at a certain site. And that's valuable with tumors because cancerous tumors tend to attract a lot of blood, need a lot of blood because they're growing so quickly. So it kind of creates a hotspot, so to speak, within the image. So here's an example of that. You can see here there's hotspots all over the place in this individual. Now there's a few places we expect it to be normally hot, so the bladder is commonly expected because as you excrete this from the blood into your bladder out of your body, you'll expect it to collect there. Now there's a couple of other areas where it tends to collect as well, like the kidneys you can see a little bit, but some of these other areas such as up here on the shoulder, within the sternum, and a lot of these spots in the pelvis are indicative of concerning areas. So that could be because of a fracture, because of cancer, because of a number of reasons. Anything that would cause increased blood to the area. Positron emission tomography is very similar to bone scan, although it allows for 3D acquisition of the data as opposed to two-dimensional. And the advantage of this is it allows you to overlay the data to a CT scan to give you a more targeted or a better understanding of where that increased radiotracer uptake is located. For example, here we can see the PET scan over here on the left, and then we combine it with the CT scan to get an idea of where we're seeing these hotspots. So you can see the bladder, that's to be expected, but then the liver is showing a lot of increased uptake, and you can see the corresponding data there. So now we're going to start with move on to the ABCs of identifying radiographic findings. So the ABCs allows you to keep a pattern or organized pattern of searching when you're going through a set of images. So the ABCs are A for alignment. It can also include anomalies in anatomy. B for bone. C for cartilage, meaning the joints, and S for soft tissues. Starting with alignment, that's often used to assess, spinal curvatures. You're looking at osseous anatomy, generally speaking, and then you can also find if there's some congenital anomalies, normal variants, and then, of course, scoliosis. So here's an example of just checking the alignment of spinal curves, among other things. But the key here is just noting where how the spine is curved and looking at the global alignment of everything. You'll notice that there's some surgical hardware in here, and the reason for that will be made clear in the next slide. So as you can see, if we look on the frontal radiograph, we can see that there is some curvature here. So this individual had scoliosis, and these rods were placed to prevent the degree of scoliosis from getting any worse. Now, if we're looking on the alignment on the right image, we notice that the humerus is not quite where it should be. So this is an alignment issue, and we can see the glenoid is here, but the humeral head is down here. So this would be an anterior inferior shoulder dislocation, but again, that falls under the alignment. Next, we look at bone. So with bone, we'll be looking at the density, contour, trabecular patterns, cortical margins, size and shape of the bone to determine if it's okay. So on this image, on the left, we're looking at bone quality, bone density, we're looking at the cortical margins, and as we trace around, we say, oh, we have a little disruption here. So this is evidence of what's called a Diverny fracture, or essentially you have the iliac wing that was fractured at some point. Now this is an old fracture because it shows signs of healing. It's got fully corticated margins all the way around it, including over here, so we know that it's old and it just never properly united with its appropriate spot. Over here on the right side, if we're looking at the bone, we can see that the cortexes look thinned, trabecular patterns aren't quite there, and then we're also noticing these very dense structures within some of the vertebral bodies, and what these are essentially it's cement injected within the vertebral body from preventing it from collapsing. So this person had some compression fractures within their spine, and these were to help prevent them from getting any more severe. So on this image, again looking at the bone, we can see most things look okay, but we have this fuzzy, more sclerotic lesion within there, and that will be indicative of a lesion that we would want to look into. Next, we're going to assess cartilage or the joints. So with this, we want to make sure when we're looking at joints, we kind of already talked about alignment, so now what we're focusing on is the articular surface essentially itself. So here we can see we have some joint space on the lateral aspect of this knee, but the medial aspect doesn't appear to have any joint space. So that's what we're assessing when we're looking at cartilage or joints, because we're expecting there to be menisci in there, we're expecting articular cartilage, and if the bone is on bone, then there probably isn't much left of that in there, so that's what we would be looking for and commenting on in the cartilage section. So on this slide, we have a few more examples of assessing the cartilage, so especially joints. So on this left image, we're seeing that there's not much of a tibio-talar or talar-fibular joint to speak of. So this would be somebody with neuropathic arthritis or Charcot's foot. And then on the right, we're looking to see what's going on within the joint space, and then there's some extra calcific mass up above the patella there, and that would be some calcification either within the joint capsule itself or maybe a little bit within the articular tendon. Soft tissues is the last major category, so we're just assessing pretty much all of the organs and skin and whatnot. So looking here, we're going to see on the left, we're looking around and we're seeing kind of almost looks like a bony structure in front of the spine that we wouldn't expect. So in this case, this is a calcified abdominal aorta, and that is something we do not expect and we should comment on. On the right, again, we've got some more calcific or bony looking like mass or structure that we're not expecting to see. Something else to look for within the soft tissues would be any kind of deformity. For example, if this shoulder was dislocated, you could see possibly evidence of a sulcus sign where the skin bows in, or if there's a fracture here at the acromion or at the greater tuberosity, you could have this broken off and then there'd be swelling around it and there would be differences or fullness within the soft tissues around it. On this slide on the left, we're going to look at the soft tissues and wonder, okay, so what's going on here? So there's a little bit of calcification here, but what's of real concern is the fact that the prevertebral soft tissues have a very large distance. So you can see the trachea here is pushed way forward. This should be back here, and that's indicative of a soft tissue mass that needs scrutinizing. So we'd have to find out what's going on there. On this right image, we're looking for any kind of soft tissue abnormalities, and if you notice here, there's some swelling, and if you look really close, there is a sliver of bone at the distal tip of the lateral malleolus. So there was an avulsion fracture there that led to that swelling. You might not always have that avulsion fracture, you might just see the swelling, but that's why it's important to pay attention to the soft tissues. So now we're going to start with this, we're going to continue with the cervical spine. We'll begin with lines of mensuration within the cervical spine. So the first line we're going to talk about is the McGregor line, and the McGregor line is drawn from the posterior aspect of the hard palate to the base of the occiput. So on this side we have a normal McGregor line, and that's identified by looking at where the dens is. So the tip of the dens is right just barely above. On this one, we have to see the tip of the dens goes well above the McGregor line, and that would be abnormal, indicating basilar impression. The Chamberlain line is a similar line, and it's evaluating the same thing. So as you can see, these images are the same, but instead the Chamberlain line is drawn by, again, from the base or the posterior aspect of the hard palate to the opistheon, or the posterior margin of the foramen magnum. So this line is not preferred over the McGregor line simply because it's more difficult to determine where that landmark is versus just finding the base of the occiput here. The cervical lordosis is measured by the inferior endpoint of C7 here and drawing a line, as well as drawing a line through the plane of C1 and measuring that angle. This would be a normal angle, and then this one would be an abnormal angle as there is no angle. So the cervical gravity line is drawn from the tip of the dens, and it's supposed to pass through the C7 vertebral body. In this case it does, but it's also because this neck is very straight, but even with the lordosis it should still pass through about the anterior third of the C7 vertebral body. Routh-Jackson lines are used to evaluate stress points within the cervical spine on flexion and extension. There are landmarks in which they're supposed to land. So on flexion, it tends to be between C5, C6, the vertebral body or articular pillars. In an extension, it should be at C4, C5 in the vertebral body or articular pillars. George's line is used to determine spinal vertebral body alignment. So in the cervical spine, we can see on the left, these line up fairly well, but on the right, we have a large break within George's line, indicating we have some anterior or posterior translation of a vertebral body relative to the one below it. This is used to help determine if there's evidence of a spondylolisthesis. In this case, this would have been an aneurysthesis of C4 on C5. The spinal laminar junction line is similar to George's line, although it uses the sclerotic density you see as the lamina meet to create the spinous, and it's helpful when used to determine where C1 is, because since C1 doesn't have a vertebral body, we have to use this instead. So in this abnormal view, you can see that the spinal laminar junction line on C1 is far posterior to everybody else's. indicating we have a posterior translation of C1. The atlantodental interval is used to evaluate the space between the dens and the anterior tubercle of C1. So on the left, we have a normal atlantodental interval, which should be about 2-ish millimeters, no more than 3 in adults. Over here on the right, we have a widened atlantodental interval, suggesting a transverse ligament instability or possibly even rupture. So now we'll look at some congenital anomalies and normal variants in the cervical spine. So a pericondylar process is a process that extends from the occipital condyle down to the C1 arch, or the C1 transverse process. They don't always communicate as depicted on this lower image here, but we know it's a pericondylar process as it always originates from the occiput. Here's an example of one coming down and actually forming an articulation with the C1 transverse process. Now, an epitransverse process is the opposite of a pericondylar process in that it originates from the transverse process of C1 and reaches up towards the occiput. So this would be an incomplete. This one would be a complete bridge. And here is an example of one forming almost an articulation on the side of the occipital condyle. The third occipital condyle is essentially an anterior articulation point for the occiput against either the C1 anterior tuberosity or tubercle and or the dens. It as you can see here, this arrow is pointing one out, so you have your occipital condyles here, and then an accessory condyle for that C1 anterior tubercle to articulate with. Occipitalization is failure of segmentation of the occiput or C0 and C1. So essentially what we're looking at here is the atlas is still attached to the base of the skull or the occiput. On a lateral view, you can see the anterior tubercle here and the posterior tubercle of the C1 are still fused to the piston and the basion of the foramen magnum or the base of the skull. So here's a larger image of that same illustration as well as an example on radiography. So here the posterior arch is just essentially an extension of the base of the occiput. Posterior arch agenesis of C1. So there's a lot of variation within this congenital anomaly, and as you can see here with this chart, there are quite a few different varieties. Now, most commonly, you'll have some form of incomplete, usually this. This can also progress to being almost complete agenesis of the posterior arch. Some examples of this, of a partial. So you can see there is some bony structure back here, but you would expect a ring of structure and or a spinal laminar junction line, of which there is not. And then here, there is simply an absent posterior arch of C1. Something you'll notice when this happens is the anterior tubercle gets larger and more sclerotic to compensate, as well as C2 forming what's called a megaspinous within that space. The os terminale of Bergman is a ununited secondary ossification center at the tip of the dens. You have to be careful to not confuse this with fracture. CT is very helpful in determining this. So some examples, or an example here where you have that secondary ununited ossification center on a coronal CT slice through the dens, and you can see that V-shaped essentially serve that interface between the ossicle and the dens. And then here's an artistic 3D representation. Os odontoideum is like a larger os terminale, but it usually includes the full dens. So again, it's an ununited ossification center where the dens did not completely ossify to the body of C2. Now, that doesn't mean there's nothing in between here. There's likely some cartilage in between, but on X-ray, you just wouldn't see that, so it looks like the dens is floating. It is also, you have to also be careful to not confuse this with a dens fracture, type 2 dens fracture specifically. Again, we have some illustrations and examples of an ossodontoideum. So here on this coronal CT, you can see the gap between the dens and the body of C2, though there's likely some cartilage in between that looks like it's just a floating dens. So, and then this is an artistic representation of that. Congenital block vertebrae are sometimes present, and to tell those, you look at the contour or the shape. So congenital block vertebrae often have this rudimentary disc in between, and they have what's called a wasp's waist deformity, which is this curvature in the front. So in this situation, you can determine if it's congenital or not based off of those key things. So like a surgical or an acquired block vertebrae often will be very straight in the front, and it'll look a lot more like a cinder, not a cinder block, but it's more rectangular, and there won't be a rudimentary disc. There can also be fusion of the posterior elements as well, but that's not always the case. Here are some examples, just like this one. This was that same example, and this is another example at C2 and C3. And you can see here the posterior elements are also fused. Congenital spondylolisthesis. So this is often caused by bilateral pedicle agenesis, meaning that the vertebral body is not anchored in place and can often slip forward, leading to an anterolisthesis. So the example here at C6 shows a lack of a pedicle on one side, leading to a mild anterolisthesis. Cervical ribs are a common anomaly that can be found on imaging. They're often incidental, but when they do create symptoms, it often gives you thoracic outlet type symptoms. On this example here, we can see on the left image, there's a cervical rib here. And then on the right, we've got bilateral but smaller cervical ribs coming off. And something to help you determine whether it's a cervical rib versus a thoracic rib is on the thoracic vertebrae, the transverse processes are angled up, versus the cervical vertebrae, the transverse processes are angled down. Spina bifida, and in this case, this is a spina bifida occulta. It's a failure of the posterior elements of the neural arch to fuse together. So there's occulta and vera. Occulta is like this, as I said, and vera would be a wider or more open type of agenesis or failure of closure. At C1, it is also called a spondylolisthesis. So here at C1, there's a spina bifida occulta noted by the lack of a spinolaminar junction line that we would expect about here. And then over here is showing a spina bifida vera. As you can see, the posterior elements of the lumbar spine are very wide and non-existent. So there's just a big opening in the back. Now we'll discuss some abnormalities. First, we'll discuss stylohyoid ligament calcification. It is calcification of the stylohyoid ligament, or the ligament connecting the styloid process to the hyoid bone of the skull. Eagle syndrome is a common syndrome resulting from this. As you can see here, these elongated projections would be our elongated styloids. Here are two examples of stylohyoid ligament calcification. On the left, we have this long bone appearing in front of the cervical spine. This would be that stylohyoid ligament calcification, and it's connecting to the hyoid bone here. On the AP open mouth view over here on the right, we can see this bone coming down in front, which would also correspond to stylohyoid ligament calcification. Now, with the eagle syndrome, that often leads to difficulty swallowing. Now we'll move on to the thoracic spine, starting with our lines of mensuration. So first we're going to discuss the Cobb angle, and the Cobb angle is used to determine essentially a degree of scoliosis. And this is the preferred measure of measuring scoliosis just due to its reduced chance for error. And the reason for that is the landmarks are the inferior end plate of the lowest most or inferior most involved vertebral body and the superior end plate of the superior most involved vertebral body, and measuring the angle between those two. The Rice or Ferguson method is similar, but instead you still use the lowermost and superiormost involved vertebral bodies, but you draw an X to find the center. And the reason why this is not preferred is it can be a little bit more difficult to find that center based off of the way the image looks and or the morphology of the vertebral body itself. Some congenital anomalies and normal variants. The hemivertebra is essentially a half vertebral body in a wedge shape, and that can be in any direction. Usually it's either the left only or the right only, but you can also have it where it's the front only or the back only, as talked about here. Some examples. So on the left side, we can see here this little wedge-shaped bone, which is a hemivertebrae creating this scoliotic curve within this individual. And then here's a CT of a different patient, but with the same type of presentation. You have this little half bone wedged in there, creating a kink within the spine. A butterfly vertebra is similar to a hemivertebra in shape, but on two sides, and it's due to a mid-sagittal cleft in the vertebral body. It has an indentation in the end plate along the center or in the sagittal plane, so you would see it on a coronal view like this, or an A to P or frontal. Because of its symmetry, it doesn't usually cause a scoliosis or a coronal curvature. Here are some examples. So here is those two wedge-shaped parts of that vertebral body and a close-up. And notice that the spine is still fairly straight. Now we'll talk about pedicle agenesis. Here, if we notice that on this body, this spine, we have the pedicles here, but this side it's missing, and then on this side it's really sclerotic or enlarged. This is a good sign because that means that this has been this way for a long time, also meaning that there's a less likelihood that this is due to some kind of malignant process. If you see a missing pedicle but the other side looks like the rest, that's very concerning for some kind of bone-destroying tumor that needs attention. Ununited secondary ossification centers are a failure of union, so essentially kind of like our os terminale of Bergman, you have these little bones that failed to ossify together with their parent bone, such as you could have a transverse process or a spinous process that doesn't quite attach to the vertebral body it's supposed to. So here we have two TP ossicles. So here's one here, and you can tell it's not a fracture because of the cortication of the piece. And same here, this one shows the cortication a bit better. Some abnormalities. So here we have an idiopathic scoliosis, and you can see the curvature here. It's less apparent on the lateral view, but we got the information we need from the A to P. This is a congenital scoliosis in an 18-month-old, and congenital because we have some congenital abnormalities leading to that scoliosis. So we have a hemivertebra actually a couple hemivertebrae. So you have one on one side and two on the other, leading to that convexity on the side with two. Next, we're going to talk about Schmoyle nodes. Schmoyle nodes are impression, or essentially you have intervertebral disc material that punches through the end plate of a vertebral body here and creates this indentation as outlined here. Here's another example of Schmoyle nodes within the lumbar spine using a sagittal slice from a CT examination. There are multiple involved vertebral bodies, and you can see it can affect either the inferior or superior end plates and can be adjacent as well in certain areas. Sherman disease is a disease that usually affects males that are in adolescence. It can create these end plate irregularities as well as anterior vertebral body wedging. Although mild, since it affects multiple vertebral bodies within the thoracic spine, it creates an accentuated kyphosis or a hyperkyphosis. They also tend to be susceptible to Schmoyle nodes. Here's an example on the left. You can see that end plate irregularity along with the mild anterior vertebral body wedging, but as it accumulates, you can see it accentuates the thoracic kyphosis. Over here on the right is a fairly extreme example just to illustrate that hyperkyphosis. Next, we'll discuss the lumbar spine, starting with our lines of mensuration. This is the lumbar lordosis, and the lumbar lordosis is measured kind of similar to as if you're measuring the scoliotic curvature. You take the sacral base or superior end plate of the sacrum along with the superior vertebral end plate of the L1, and then you just find the angle between those two. The lumbar gravity line is done by finding the center of L3 and drawing a vertical line straight down. That line should intersect S1, especially the anterior third. Here it's a little close to the tip, but it still intersects, so we're good. The Ullmann line is drawn by drawing a line through the sacral base and then a perpendicular line at the anterior aspect of the sacral base, and we're expecting the L5 vertebral body to be at or behind that line. It's a method of just determining aneurysthesis. Hadley's S-curve is drawn from the inferior aspect of the TP here, and it curves around through the articular process or articular pillar, and if it's broken, it might suggest some facet joint disruption. The McNabb line is drawn from the inferior end plate of one lumbar vertebrae, as you can see here, all the way across through the posterior elements, and the superior articular process of the inferior vertebral body should not cross that line, or it might suggest some facetal imbrication or occlusion of the intervertebral foramen here. Meyerding's method of spondylolisthesis grading. So to do that, we just pretty much divide the sacral base into 4 sections, and then we look and see where L5 sits on the sacral base, which section, and actually can be applied to any other. So if it was L4 and L5, we would just divide L5 superior articular surface into 4 zones, and we would just determine the level of slippage of the vertebral body over the one below. Now we'll discuss congenital anomalies and normal variants. Lumbosacral transitional segments. So the way these work is you have the TP either grows, articulates, or fuses with the sacral ala. And it can be unilateral or bilateral. In this case, we have a unilateral type 3 because we have fusion. Here is the classification system by Castelvi, and you can see the Type 1 is just an elongated or widened or spatulated transverse process. Here it's bilateral. Type B, bilateral. A for unilateral. Here, type 2, we have an articulation. Type 3 is fusion. And type 4 is mixed. So usually you'll have a type 2 and a type 3. Radiology syndrome is something that follows from a type 2A transitional segment. So you can see this unilateral. It can be others too, but usually type 2A. You can see here we have this articulation between the L5 transverse process and the sacral ala, and it creates pain in this individual. So that's why, and then Radiology syndrome is the name for that condition. Nuclear impression is caused by notochord remnants, and it creates this undulating or Cupid's bow type appearance to the end plate of the vertebral body. Oppenheimer's ossicle is an accessory ossicle at the superior or inferior, articular facet of the lumbar spine usually. So it's an incidental finding. We can see one here just hanging out, and usually doesn't cause issues. So spondylolisthesis, this is again showing that Meyer-Ding's method. We've got the 4 zones, and it just kind of helps you determine how severe it is. And then spondylolisthesis, you can have either an anero or a retrolisthesis. Anero is like what's depicted in this image. Retro would be posterior migration of a vertebral body over the one below. Here is an example. So here we can see that the L5 has slid forward over S1. I would say this is probably a grade 2. There are 6 types of spondylolistheses. So dysplastic would be a kind of congenital type reason for the spondylolisthesis. So you'd have like elongated pars, or you have elongated lamina that allow the vertebral body to slip forward. Isthmic would be your traditional pars fracture that we talk about. So you would see a defect in the pars interarticularis allowing the vertebral body to migrate forward. Degenerative is just, again, caused by degeneration. You might have facetal arthrosis or something leading to anterior slippage because those facet joints aren't able to do their job. Traumatic would be a fracture, but anywhere except for the pars, so lamina or spinal laminar junction or pedicles. And that fracture allowing the vertebral body to move forward. Pathologic would be because of either a tumor or infection or something destroying any kind of structures like any posterior elements to allow the vertebral body to slide forward. And then lastly, iatrogenic, or essentially intervention-based or surgical-based reasoning for it. So if somebody went in and had a laminectomy, for example, and then a spondylolisthesis resulted after that, that would be considered iatrogenic. A limbus bone is essentially a special type of Schmoll node. And what happens is you get nuclear material, instead of punching out a divot, it shoots under the ring apophysis of the end plate of the vertebral body and shears off a corner of the bone. So this will usually only happen in skeletally immature individuals, so people who still have open ring apophyses on the end plates of their vertebral bodies. Here's an example of a limbus bone. Here's another segment on Schmoll's node, just like in the thoracic spine. Again, it's the indentation within the end plate, either superior or inferior, due to nuclear disc material punching into the end plate of the vertebral body. And that same example with multiple end plate fractures. So the Dennis 3-column concept is where we divide the spine into 3 columns, and this is to determine spinal stability. So you have an anterior, middle, and a posterior column. So For example, an anterior vertebral body fracture is considered stable because you still have this middle or posterior aspect of the vertebral body as well as the posterior elements maintaining the stability. Now, if you have a burst fracture where 2 or even 3 are involved, then we have an unstable fracture and there needs to be some form of intervention. Moving on to the pelvis. Lines of mensuration. So we have the Reiser classification, which is used to determine skeletal maturity. This is typically used when determining what to do for somebody with scoliosis, and that's why it was originally invented, I guess you could say. So what you do is you look at the apophysis here on the edge of the iliac crest, and you determine how far it's ossified. So as it creeps over, we go through various stages, with stage 0 being none, and stage 5 being complete. So it's all the way across, everything is ossified and fused. Now, if you have apophysis on just like less than a quarter, less than a half, or less than 3/4, etc., you get these various stages of skeletal maturity. Pelvic leveling is done by just placing horizontal lines directly over the tops of each iliac crest and seeing how much the difference is. It's used to determine pelvic distortion or leg length inequalities, that type of thing. Femoral head leveling, it's the same idea, horizontal lines across the top of the femoral heads and determining what that leg length discrepancy or maybe some kind of pelvic distortion from there, subluxation. Congenital variants and congenital anomalies and normal variants. So we have the paraglenoid sulcus. That is this feature here just to the lateral aspect of the SI joint. You have one on each side here. So they're just these incidental and harmless findings in the pelvis. Caudal regression syndrome is a pretty severe syndrome of agenesis of the sacrum. So here you can see how the ilia just come together and meet, and there's no actual sacrum between the ilia of the pelvis. There's a number of things that can happen because of this, as well as some or other types of deformity that are tied to this syndrome. So here are two examples, one in a neonate. As you can see here, there's no sacrum or even really much of any lumbar spine to speak of. And then in somebody who has developed, you can still see the similar deformity within the pelvis. Moving on to the thorax, congenital anomalies and normal variants. So here we're talking about rib synostosis. With rib synostosis, you have a congenital fusion of the ribs due to failure of segmentation. So here are some of these mid-thoracic ribs. You got 3 of them partially fused together. Here's another example of a cervical rib actually connecting to a first rib. Eventration of the diaphragm is a congenital weakness of the diaphragm muscle. It tends to create like a bubble or an outpouching, or this, as they say, wavy contours. So you can see here, you have this funky little like molehill on top of the liver. So this would be due to muscular weakness within the diaphragm, and it is called eventration of the diaphragm. Pectus excavatum is a condition where the sternum kind of protrudes into the chest, leading to what they call funnel chest, or this like pushed in chest. It can be severe if there's a severe reduction in A to P thoracic dimension, because you'll have mediastinal structures pushed to the side, interfering with lung function, causing heart problems, that sort of thing. So here's an example of a pectus excavatum within an individual, and it's a little bit evident here on this lateral thoracic radiograph because the sternum is pushing in more than it would. Usually it would come more straight down. So this is indication of pectus excavatum in this individual. The azygos fissure is a accessory fissure in the lung that looks like a tadpole, and what it does is it kind of wraps around the azygos vein from the spine. So here it's kind of painting over where it appears. So if you look on the image, you can see kind of this tail with a head of a tadpole, and that's because the azygos vein is living right in there and creating that fold within the pleura. Moving on to the hip, our lines of mensuration, we're going to start with the femoral angle. So you place a line straight through the femoral diaphysis with a line through the femoral neck, and then you measure that angle, and it should be between 120 and 130 degrees. Klein's line is taken by drawing a line straight through the superior aspect of the femoral neck, and some of the femoral head or that epiphysis should be crossing over the line. If it doesn't, that's indicative of slipped capital femoral epiphysis. Shenton's line is drawn from the inferior or medial margin of the diaphyseal cortex up through the inferior femoral neck and then across the inferior cortex of the superior pubic ramus. This should be a fairly continuous line, and if it is not, it could indicate some developmental hip dysplasia or fracture of the femoral neck or head. The Skinner line is drawn by drawing a line straight through the femoral diaphysis with a perpendicular line going straight through the perpendicular line to that diaphyseal line and a tangential to the greater trochanter. The fovea capitis should lie at or above the level of the trochanteric line, and if it doesn't, it could be because of some kind of coxivara deformity or superior displacement of the femoral head. Kohler's teardrop is used to measure, or Kohler's teardrop distance is used to measure the medial joint space of the femoral acetabular joint. And you draw a line at the lateral margin of Kohler's teardrop and then the articular surface of the femoral head and measure that distance. The ilioischial line or Kohler's line is drawn from this medial aspect of the ilium through the ischium, and it is used to determine protrusio acetabuli or femoral head migration through the pelvis. And it can be indicative of some bone softening conditions or something of that nature, or a hip fracture. The iliofemoral line is done on the outer ilial cortex across the top of the acetabulum and then through the femoral neck. A smooth line indicates normal alignment, whereas if it's not smooth, you might have evidence of some kind of hip dysplasia or skiffy fracture, those types of things. The center edge angle is taken by drawing a point at the center of the femoral head and drawing out from that to the edge of the acetabulum, as well as drawing a vertical line from that same central point of the femoral head and measuring the angle in between. So if the angle is too small, it might indicate there is incomplete acetabular coverage, or too much coverage if it goes too wide. Now we'll talk about some congenital anomalies and normal variants. Starting with os acetabuli. So os acetabuli is an accessory ossicle on the superior margin, typically the superior margin of the acetabulum. It can be a risk for impingement syndrome, and you want to make sure you don't confuse it with a fracture. So here's the ossicle here, floating just lateral to the superior margin of the acetabulum. Developmental hip dysplasia is a congenital or developmental displacement or dysplasia of the hip. So here, if we notice on this left hip or left femur is migrated superiorly and is not properly articulating within the acetabulum relative to the left or the right hip. and we can see here that the Shenton's line is broken. Some of these other lines here are called Hilgenrainer's line and Pelkin's line. They are used to help determine presence or absence of developmental hip dysplasia. Here are some examples of developmental hip dysplasia with a unilateral example here on the right, or I'm sorry, the left, and then a bilateral example on the right. So here you can see how the femurs are articulating essentially within the iliac or the ilium bulls, and then here we have one riding pretty high, whereas the other femoral head is articulating correctly. A synovial herniation pit or a Pitt's pit is an incidental finding where you have a herniation or impaction type fracture of synovial material into the femoral neck, and they're usually are a non-issue and don't need to do anything about it. Moving on to the knee, lines of mensuration. Starting with the Insall-Salvati ratio. The Insall-Salvati ratio is used to determine the presence of either patella alta or patella baja, pretty much determining where the patella is in the knee articulation and making sure it's in the correct location. It should fall, this ratio is done by measuring the length of the infrapatellar tendon as well as the length of the patella itself, and this ratio should fall between 0.8 and 1.2, so they should be essentially roughly equal. Patella alta is when the patella is situated more superiorly than it's supposed to, often can indicate infrapatellar tendon rupture. So here we can see that there is the infrapatellar tendon doesn't seem to be connecting to the tibial tuberosity. Patella baja is the opposite, where the patella lives a lot lower, and this can cause a lot of articular derangement or problems with the knee articulation and dysfunction. Congenital anomalies and normal variants within the knee. So we have a bi or a multipartite patella. That is where you have what looks like a fracture in the kneecap. So you can see here you have this piece up here, but the bipartite or multipartite patella will almost always be in the superior lateral aspect of the patella, whereas a fracture most commonly will transverse through completely or create like a star-shaped fracture pattern. If you even have multiple pieces, so like if it's a tri or a multipartite, they'll all typically be clustered in this superior lateral corner. An os fibella is essentially a sesamoid bone within the lateral head of the gastrocnemius. You can see it here, and it's an incidental finding. Some abnormalities. Chondromalacia patella is a derangement of the articular surface on the posterior aspect of the patella. You can kind of see a little bit of it osseously here, is that the joint surface is irregular. It often is caused by contours or crevices, cracks within the articular cartilage, leading to pain and crepitus. Osgood-Schlatter disease is a repetitive stress injury or fatigue injury with at the tibial tuberosity and the infrapatellar tendon insertion. In this example, you can see some bone kind of forming within that region or that tendinal insertion site, and a lot of times this happens with repeated stress, and it creates, you can actually even see the soft tissue bump as this person has been chronically stressing that tendinal insertion. If it goes too long or it gets too severe, it can result in avulsion of the infrapatellar tendon from the tibial tuberosity. Sinding-Larsen-Johansson disease is the inverse of Osgood-Schlatter's, whereas instead of being at the tibial tuberosity, you have the similar situation but at the patellar apex or the inferior pole of the patella. A Baker cyst is a synovial-lined lesion or extrusion of the joint capsule from the knee to the into the posterior musculature. It usually is caused by a valve-like opening that allows fluid to only move one way. So you get this cyst-like structure that forms behind the knee. In this case, we can actually see it because it has calcified. Normally, you wouldn't see it on radiographs. You would use an MRI to visualize and/or clinical findings. Now we'll move on to the foot, beginning with our lines of mensuration. Starting with heel pad thickness, we measure from the posterior aspect of the calcaneus to the edge of the heel, and we just measure the thickness of the soft tissues there. It should be 2.5 centimeters or less. If it's larger, it may indicate the presence of a pituitary adenoma within the individual. Bowler's angle is used to determine the presence of fracture within the calcaneus. So there are 3 tubercles on the calcaneus. You have the anterior, middle, and posterior, and you draw a line over the anterior and middle, and then another one over the middle and posterior. You measure the angle between them. If it's less than 28 degrees, then you should be suspicious for a fracture within the calcaneus. Some congenital anomalies and normal variants. Hallux valgus of the first toe. So you have a valgus deformity here at the first digit of the foot, and you can see here how far off it goes based off of this angle measurement. And when you have this, it can lead to pain, poor foot biomechanics, and bunion formation. You can see the bunion is starting to form out here. Symphalangism is when you have a phalangeal synostosis in a sense. So you've got the digits are lacking their ip joints here, and in this case, yeah, the interphalangeal joints are all missing. And so you have pip, 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 and then ip here. Their distal phalangeal joints of the second, third, and fourth digits are still present, but their proximals are missing. This can cause just biomechanical type aberrations or some uncomfortable type or lack of flexibility, and then usually it's an incidental finding. Polydactyly is essentially extra digits, so you have too many digits on your hand or your foot. Moving on to the shoulder, lines of mensuration. Acromioclavicular alignment. So with this one, we're looking at the inferior margin of the clavicle, so here, and the inferior margin of the acromion here, and we're making sure they're lined up. If there's a disruption here, we're going to be concerned about the integrity of the acromioclavicular ligaments, as well as if it's severe enough and superior, we might question the integrity of the ligaments here, usually the corticoclavicular ligament, or acromioclavicular, corticoclavicular. So the acromiohumeral interval, which is drawn from the inferior cortex of the acromion to the superiormost cortex of the articular surface of the humerus, that is used to determine whether there might be some presence of impingement there, disruption to the supraspinatus tendon, any other structures that might run underneath the supraspinatus or deltoid bursas, and can help us determine whether there's impingement. Some congenital anomalies and normal variants. So this is Sprengel deformity, and Sprengel deformity is elevation of the scapula that is not normal. So you can see on the right side we have scapula in its correct position, but then on the left the scapula is riding a lot higher. Now, Sprengel deformity can also come with something called an omovertebral bone, where you'll have an osseous bar that bridges between the medial border of the scapula and the spine. It is commonly associated with Klippel-Feil as well. Os acromial is a secondary ossification, ununited ossification center, or a secondary ossicle, accessory ossicle here at the tip of the acromion. So you can see the acromion process has developed this ossicle where they either didn't unite or it's an extra bone. At the elbow, starting with lines of mensuration. We have carrying angle. So the carrying angle is the angle between the humerus here and the ulna. Normal carrying angles between men and women are slightly different, but usually should be 11 degrees for men and 14 degrees for women. Anterior humeral line is used to determine the presence of distal humeral fractures. So you draw a line down the anterior surface of the humeral diaphysis, and then you measure where the articular surface, distal articular surface of the humerus lies. So if this migrate is back here, we should be suspicious of distal humeral or supracondylar fracture. The radiocapitellar line is drawn through the diaphysis of the radius, and then it should intersect through the capitellum. It is used to determine fracture or dislocation of the radius relative to the capitellum. Some congenital anomalies and normal variants. We have an olecranon foramen, which is a foramen where the olecranon fossa should be, happening because the bone didn't form and likely because the olecranon fossa was just too deep. This can pose a risk of increased supracondylar fracture or distal humeral fracture, but otherwise is an incidental finding. Radial ulnar synostosis is where the proximal aspects of the radius and the ulna are fused, reducing pronation and supination of the forearm. It is often bilateral and is rare. Supracondylar process is a bony spur at distal or proximal to the humeral ulnar joint, or the elbow, and it points towards the joint. And that's important to note because osteochondromas, which can look very similar, point away from the joint and often have a more fluffy, indistinct end to it because of the cartilaginous cap that they have. Also, on a supracondylar process, you often can have what's called a ligament of Struthers that connects from the tip to the distal humerus, and it creates kind of like a foramen that neurovascular structures that can pass through, typically the median nerve, and it can create some kind of radicular or distal peripheral nerve neuropathies. Now with the wrist, lines of mensuration. Arcs of carpal alignment will be the first that we discuss, specifically, or aka the Galula, 3 carpal arcs. So these are created, the first carpal arc is created by the proximal cortex of the proximal carpal rows. So you have the scaphoid, lunate, and triquetrum proximal cortices creating the first arc. The second arc is created by the distal cortex of those same 3 bones, and then the third arc is the proximal cortex of the capitate and hamate here. And it is to help us just make sure that the carpals are in their correct alignment. Some congenital anomalies and normal variants. Ulnar variance is a discrepancy or difference in length of the ulna distal ulna relative to the radius. It can be longer or shorter, and if it is shorter, it tends to lead to TFCC tears, versus if it's longer, it can impact or crush the TFCC, leading to also thinning and tearing. If you have a negative or shorter ulnar variance, then you can have impingement and osteonecrosis of the lunate. So on the left, we have a positive ulnar variance. You can see how it's a little bit longer than the radius, and on the right, we have a negative ulnar variance where it is shorter than on the right, or than on the radius. Madelung deformity is caused when you have premature closure of the medial aspect of the distal radius epiphysis, or physis, so right in here. And because of that, you create this funky angulation, and you get this V-shaped articulation for the wrist. It can also create an anterior bowing or a distal subluxation of the anterior bowing of the radius, or distal or posterior subluxation of the ulna. So here's that in an example of that. So you have the ulna here, which is kind of posteriorly displaced, or the anterior bowing of the radius is shown here. Carpal coalition is the failure of separation of two or more carpal bones. Most commonly involves the lunate and the triquetrum. So you can see here you have the scaphoid, and then you'd expect both a lunate and a triquetrum, but they're both one bone. If you look, you can see a very slight like articular or rudimentary disc almost like structure there where they should have separated but didn't. Next, the hand, looking at congenital anomalies and normal variants. So this is an example of syndactyly. Syndactyly is the fusion of two or more digits within the hand or the foot. It can occur as an isolated phenomenon or be associated with other syndromes or entities or conditions. Of note, syndactyly is a fusion of only the soft tissues, so the osseous tissues or structures will remain distinct, even though there is that soft tissue fusion. Polydactyly, again, is a extra digit on the hand or the foot. Some extra information on that, we have the preaxial versus postaxial. Preaxial would be extra digits on the side of the thumb or the big toe. Postaxial would be extra digits on the side of like the pinky finger or toe. So now we're going to look at some multi-region or systemic anomalies, starting with dysplasias. Actually, we'll just be talking about dysplasias. First being osteogenesis imperfecta. So osteogenesis imperfecta is a type 1 collagen condition that leads to severe or varied, but can be mild to severe weakening of the bone. So it affects quantity and quality, and that widely varying degree of severity can lead to minimal or even no deformity to severe deformity with death perinatally. So you can have a lot of fractures, and it's commonly seen with blue sclera, hearing loss, abnormal bone fragility, and poor dentition. So the teeth are also infected to the similar degree of the rest of the bones. Here are a set of examples showing some of that thin gracile bones that you tend to get along with fracture, and then here again another fracture within the femur, sometimes creating pseudo-articulations, so joints essentially where they don't belong. Here again another set of very thin and gracile wavy bowed bones with a fracture here in the proximal femoral diaphysis. Achondroplasia is a congenital disorder that affects fibroblast formation, and it leads to endochondral bone formation, so long bones. And this typically causes what's called a rhizomelic type of dwarfism, meaning the proximal bones within a limb, so like humerus and femur, are more severely affected than the distal, so radius, ulna, tibia, fibula. So this tends to cause short stature, shortening of long bones. You have a champagne glass pelvis, which is a type of radiographic sign. You have reduced interpedicular distance within the lumbar spine, a narrowed foramen magnum, and then trident hand is a anomaly or something that tends to happen. Starting on the left, we can see an example of the trident hand where you have that mid V with similar in length fingers creating a trident appearance. This middle image is showing that rhizomelic type of dwarfism where you have the proximal bone, or the humerus in this case, suffering from more severe shortening than the distal bones in the forearm, i.e. the ulna and the radius. And then here we can see some of the pelvic anomalies as well as bowing within the femurs. A few more examples for achondroplasia would be the narrowed foramen magnum. So you can see there's less room for the spinal cord and less room flow for the CSF. And then here, some of the bowing deformity and more severe shortening of the femurs relative to the tibia and fibulas. One other thing is the champagne glass pelvis. So you can see here kind of forms the shape of a champagne glass. Osteopetrosis is another condition due to defective osteoclastic activity. So the cells that clear away old bone aren't working correctly, so you have this increased density, but it's a poor quality bone, making the bones weaker. This also is evident on radiographs by overgrowth of cortical bones. So you have what looks like really dense, strong bones, but in this case, they're actually not stronger. Some examples, we have the increased density shown here, and this actually illustrates an issue that osteopetrosis causes is the reduced medullary space and reduced trabecula means there's less red marrow, so you have reduced hematopoiesis or blood cell creation. This middle image is showing something called sandwich vertebrae, so you can see these really well-defined, sharp, sclerotic end plates creating what looks like a sandwich in the spine. And then on this last example on the right, we have the bone within a bone appearance where you have what looks like bones inside the bone, so like you have that appearance. Osteopathia striata is a congenital dysplasia where you get these vertical sclerotic lines within metaphyses and epiphyses of long bones. It's typically asymptomatic and therefore a incidental finding. So here you can see the vertical lines within the distal tibia, and it was likely found when they're imaging to determine if the ankle was fractured, in which case this distal fibula was fractured. Another example here showing those vertical sclerotic lines on both the femur and the tibia and fibulas. Osteopoikilosis is a dysplasia with multiple enostoses or bone islands. So you've got these bone islands and multiple, creating a polka dot type of appearance within the affected bones. It is an incidental finding and is often found, or at times found, with osteopathia striata and malariastosis, which we'll talk about next. So quick examples of osteopoikilosis. So you can see here the bone islands all throughout the pubic ramus and ischiums, as well as the femoral neck and the acetabular regions, and in the pubic symphysis. On this example of the foot, you can see bone islands all through the tarsal bones, metatarsals, and phalanges. And in this case, the calcaneus. Yeah, so pretty much the whole foot demonstrating these bone islands. Malariastosis is uncommon, but it's a mesenchymal dysplasia where you get these sclerosing bones with a dripping candle wax type of appearance. It can affect one or many bones, but is usually found only in one limb. So it's an asymptomatic condition that is usually found asymptomatically, but if there are symptoms, you can have a number of things such as joint contracture, muscle atrophy, sclerodermic skin changes, tumors, or hyperpigmentation of the skin over the area of the affected bones. Here are some examples. So here it's affecting a couple of ribs, and you have kind of that wax, dripping candle wax type appearance here along with the sclerosis, so it looks kind of more dense. And then in this femur and the femoral neck and diaphysis, you have some of those thickened kind of candle wax type appearances.